All right, so I think we'll get started. Good evening, everyone. My name is Franchino Porciuncula. I'm a research assistant professor here at Boston University. First of all, I would like to thank Dr. Joan Breen from Whittier Rehab at Bradford for the invitation, and to Joanne Swiderski for organizing and coordinating this continuing education presentation tonight. I work here at Boston University as a research assistant professor, and my work is in developing rehab technologies for people who have neurological disorders spanning stroke and Parkinson's disease. What we'll be presenting tonight is on stroke. I am joined by my colleague, Teresa C. Baker. She's a research physical therapist here at Boston University, and she does research at our labs at BU and Harvard. Do you want to say a few words, Teresa?
Oh, certainly. Welcome to everyone. Thank you so much for joining. As Franchino mentioned, I'm a physical therapist. Part of half my role clinical in outpatient physical therapy for the most part for people with neurological conditions. And then the other half of my week is involved in the research projects. So I'll share a little bit more of this one particular research study. But Franchino and I work together, and we're so pleased to be here tonight. Thank you.
Thank you, Teresa. So our presentation tonight is on innovating gait rehabilitation programs in post-stroke rehab using next generation robotic wearable robotics. This is work coming out of our labs at BU and Harvard, and I would just like to acknowledge our team. Let me see if I can progress to the next slide here. We are a team of physical therapists, engineers, biomechanists that develop these technologies. And what's very special about our study is that this has been done in partnership with Whittier Rehab at Bradford, with the leadership of Dr. Joan Breen and physical therapists Sandy Kiley and Angela Leonardo. When we develop these technologies in our lab, we always worry whether these technologies would be able to reach the clinic, and that's our main goal. And Dr. Breen really has championed the translation of these technologies in the lab to be used and to be tested in the clinic. So we're really very grateful. And we're also very appreciative of the skill and talent of Sandy and Angela in providing the intervention and being just very skillful in being part of the study. So very big thank you to the Whittier team. So walking after stroke is characterized by slow speeds. Walking is asymmetric and it's inefficient. It is very labor intensive. And this is a big problem because slow walking speeds reduce one's overall mobility, and it has an impact on one's daily physical activity. And we know how important physical activity is in our overall health and well-being. Ultimately, these slow walking speeds reduce one's overall health and degrades one's quality of life. Practically speaking, walking speeds is what determines one from being a household ambulator, someone who's primarily homebound, versus someone who is able to walk out in a community and engage in society. So it's a really big problem after stroke, because these problems of slow walking speed, it is persistent, it goes on for years and decades, and it is hard to address. Walking speed is regarded as a single most important indicator of functional independence in people post-stroke. Therefore, this is an important rehabilitation target. However, the interventions that we have in rehabilitation are generally insufficient or not capable of really restoring walking speeds. Therefore, we are unable to really change or substantially alter the common prognosis of walking disability and stroke. While there are many factors that may contribute to slow walking speeds and stroke, we look at the movement system to understand what particular mechanisms underlying walking speeds that can be targets for rehabilitation. So with that, I'd like to do kind of like a quick review of what walking is. Well, functionally, walking is getting from A to B, right? But essentially, walking is repeated forward stepping. And stepping is comprised of a sequential completion of walking subtasks. And what are these subtasks? So we look at a particular stride marked by the blue shaded leg here. And a stride in this particular diagram starts with heel strike on the leftmost person, all the way to another heel strike as the person takes another step forward. So that is one full gait cycle. And we can look at the gait cycle based on these subtasks. As the person puts their foot down, the limb accepts weight. This is the weight acceptance or support phase, followed by a propulsion subphase or subtask, where the limb now has to push off the ground to advance that limb forward. The ankle, plantar flexors, or the calf muscles are the primary generators of propulsion, essentially pushing the body center of mass upward and forward, allowing the person to take another step and swing the limb forward, and progress onto this ground clearance phase, where essentially the person just functionally shortens the limb to advance the limb forward. And this repeats over and over again as a person takes a step or as a person walks. And what is impaired in post-stroke walking is this propulsion subphase, this middle part here. To give a demonstration of how these forces behave, or how these forces are being generated when we're walking, we have here an animation. This is actually a model that we typically see on our screens when we measure these forces in our lab. But what you can appreciate here are the propulsion forces. These are the colored or the shaded curves on the top and bottom, the blue and red for the right and left leg. What you can see here is that they are repeating. It's a repeating pattern of these forces. When someone walks faster, these forces or these traces are much bigger. They're higher or taller. And when someone's walking slower, these are not as high. So basically, these forces are modulated when someone's walking. In healthy walking, we see this pattern. It's repeating, it's symmetrical. However, in post-stroke walking, forces that are generated by the paretic limb, the weaker limb, is much lower, so it's asymmetric. And imagine the consequence of this gait interruption that's happening at every step. Ultimately, this is very disabling and it slows down walking. Zooming into what we might be seeing on traces that looks at propulsion forces between the paretic limb, the weaker limb versus the non-paretic limb. And this is marked by the blue and the red. Blue is the weaker limb. And we are seeing here, this is a representative trace of how substantially reduced this is in this particular example, but this is not very uncommon in folks that we see in our lab. So essentially, there is this asymmetry in propulsion forces between limbs. And this is an important factor that could explain slow walking in people post-stroke. Why is it important that we even consider messing around with these propulsion forces? It matters because as what we're showing here on this plot, paretic propulsion forces are related to 6-minute walk test distance. The 6-minute walk test is a common test that we do in physical therapy. It's a test of long distance walking where we ask the person to walk or cover as much ground as they can in 6 minutes. And we're showing here that these propulsion forces are associated with 6-minute walk test distance. And this is important because the 6-minute walk test distance has an implication on one's overall daily steps. And the 6-minute walk test is the single strongest predictor of community walking activity after stroke, tying again the importance of propulsion in one's daily mobility. So here we have a clinical challenge. As we have shown in the animation, propulsion forces are forces, and forces are hard to see, especially without instrumentation. But this is just a demonstration that how big a problem this can be. So again, this is a representative sample or a person who has substantially weak propulsion generating forces, as shown here by the animation on the bottom, where we're showing the paretic limb here is the leg that's closest to your screen, the right leg of this gentleman. And the propulsion that he is generating is only 1/18 of what the non-paretic limb is doing. So very big asymmetry there, which explains slow walking. Another challenge that I want to highlight here, perhaps this is more appreciable in clinical settings, is how limited our toolbox is. This is a technological challenge. When we work with people post-stroke get better with walking, we typically consider assistive devices to aid with their walking. However, our toolbox is limited. We are still using devices that are not really specific to restoring this problem of propulsion. As an example here, we have this AFO brace, which we still heavily use in clinical practice to allow people to gain early independence in clearing off their foot off the ground. However, the limitation here is that it actually impedes plantar flexion movement, which thereby prevents the person from even performing a push-off movement on their ankle when they're walking, thereby really not allowing them to even engage their calf muscles to push off, to improve on that propulsion function. When we think about our interventions in therapy, I think it's also very important to understand what paradigm we are harnessing. Is it a recovery-based type of intervention, or is it a compensation-based intervention? And I think this is defined by, we can apply this concept across the different levels of the ICF, from a health or neuronal activity or body function and structure. I'm going to focus on activity and body function and structure, just because those are more relevant to what we do in therapy. Essentially, compensation-based strategies or interventions are strategies that promote the use of alternate end effectors, basically using other muscles or other limbs to accomplish a task. For instance, if someone's having a hard time taking a step forward, typically what we see in the clinic is that people would either hike their hip, or they would circle their leg around, or circumduct to be able to advance their limb forward. That is a form of compensation. A recovery-based intervention is an intervention that promotes the usual muscles or limbs that other non-impaired or people who have intact neuromuscular systems would typically use. So if the person were to bring their leg forward, they would be using their ankle plantar flexors, let's say, for this particular example. We think it matters because when we look at the typical trajectory of one's mobility after stroke, so we see here that at the onset of stroke, there is a sudden drop in mobility, and then they gain some as they engage in intensive acute or subacute rehab. And typically, this is when we use some of these strategies. Some of them are self-learned. It is typically the path of least resistance. They self-learn and they figure out a way on how to do it. And normally, it's not the most efficient way to actually restore movement. So we see these common examples of circumducting, hip hiking, or the use of AFOs, which are not necessarily promoting the restoration of walking function or getting that walking speed. So they get continued increase, but it stops at a certain point, and then at discharge, it goes back down because the person is unable to sustain these walking strategies. There are sedentary behaviors that further complicate one's mobility. So it becomes kind of like a chronic problem that is hard to change. So in order to really change the course of, to change the prognosis of walking disability, I think we have to think of ways on how to restore walking function. In doing so, we typically utilize assistive devices. especially when we're dealing with people who have weaknesses or, hemiparesis. And it ranges. There's a landscape of devices that we typically consider when we're doing gait training in people post-stroke, from passive assistance like the AFO, all the way to active assistance with these high-powered rigid exoskeletons. It also goes up and down based on how much movement these devices are offering to the person. Some of them are imposing movements onto the person. An example of this one would be these rigid exoskeletons. And then some of these devices provide unrestricted movements, such as when someone's using a cane. When we consider neuromotor impairments and stroke, typically we need to give them a little bit of assistance targeted at a specific joint. In this particular case, if we consider the propulsion subface as a particular problem subtask in the gait cycle, how can we then provide the right type of assistive technology? So we think there is something that could have some potential between this unrestricted kinematics and assistive assistance in the form of these soft wearable robots, which we call soft exosuits. So our labs at BU and Harvard have pioneered the development of these next generation wearable robots called soft exosuits. These are essentially textile-based robots that provide just the right amount of assistance targeted at a particular joint that we think is in need of assistance. In this case, it's the thoracic ankle. This is what we do in our lab. We are comprised of a diverse team of specialists spanning the disciplines of physical therapy, engineering, movement sciences, and apparel design. And we converge our thinking and our skills to develop this new type of technology, which are called exosuits. These are essentially textile-based, wearable, lightweight robots that are powered by cable-driven actuation. Basically, a cable is assisting the person's limb as they're walking. So here, as we have presented the problem of propulsion, walking here is slow and propulsion forces are substantially reduced. When walking with a soft robotic exosuit, it immediately augments. So this is just a trace of that problem in propulsion asymmetry. When wearing the soft robotic exosuit, we are able to immediately improve on walking speed, accompanied by augmenting propulsion, as shown here by an increase in propulsion, the blue line here. To further just be clear on how this is working, this is providing mechanical assistance. So I'm just going to zoom in and slow down the video a little bit so you can appreciate how the cables are retracting, timed at the right moment in the gait cycle. So the back cable pulls right at push-off phase, assisting the plantar flexors to generate propulsion, and the front cable assists the ankle to clear the foot or the toes off the ground when they're swinging the leg forward. The I share the results of our clinical trial, I just want to summarize the development or the sequence of research that we have done to get to this point in our clinical trial. So it's been a systematic staging of investigation to be able to even use this in the context of gait training. We start with validation through, we develop the device, and over the past 5 years, we have been doing iterative work to develop and optimize the device, making sure that what we think the exosuit should be doing, it should be providing, which is to augment propulsion, followed by early clinical pilots. And then this is what we're going to be focusing more on today, the single arm clinical trial. So to quickly summarize, we have shown in our validation studies that the soft exosuit is able to improve on propulsion symmetry. When powered, as shown here by the red bar, we see an improvement in propulsion symmetry. So a lower value here means it's better, it's more symmetric. And this is accompanied by improvements in walking speed, both comfortable and fast. The red bar here is when the exosuit is powered, and you would see here that there is meaningful increases in walking speed of 0.14 meter per second. And MCID, or the minimum clinically important difference here, is 0.14 meter per second. And this is also accompanied by benefits on reducing these compensatory movement strategies that are ultimately energetically inefficient. One example here is circumduction. These are line traces of the limb, and as you would see here, it kind of like mirrors the shape of what typically happens during circumduction, where the leg is swinging outward, then forward rather than straight forward. The red trace here shows a smaller circumducting shape. And hip hiking is another common example we see in the clinic, where the person hikes the hip or elevates the hip to advance the leg forward. With powered assistance of the exosuit, we see a reduction in the vertical displacement of the hip. Moving forward with how we transition from single session validation studies, looking basically at what happens when the system's powered on versus off. Now we're looking at how can we use the exosuit in the context of gait training. And we're looking at therapeutic effects. These are effects that are maintained beyond the use of the exosuit, meaning when we look at therapeutic effects, these are changes that happen when the person's walking outside of the device. We started with a single subject study. The blue bars here show that the person's walking speed over months, or actually over 2 years, is pretty stable. Then this gentleman engaged in this high intensity speed-based gait training program, and we see meaningful increases in walking speed, both comfortable and fast, as well as in their long distance walking function based on a 6-minute walk test. This is accompanied by improvements in propulsion. This is very encouraging, and we wanted to get some understanding of how it might compare with a dose-matched intervention of speed-based training without exosuits. So we did a small study, 4 people. It's a crossover case series, meaning that all participants received both interventions, their speed-based gait training with exosuits, and a dose-matched intervention that did not involve the use of exosuits. The orange bar here is this real gait training, which is the intervention that used soft robotic exosuits. We see a significant and meaningful increase in the 6-minute walk test distance of a change of 6 to 8 meters, which is really very promising. When we look at individual participants, we had 4. What we're seeing here is that we have 3 good responders in favor of the robotic exosuit training or real gait training, and 1 person had comparable responses or effects after control training and real training. Not so shocking, because we know this intervention is not for everyone, and we wanted to understand more what are mechanisms that might explain one's response to this particular intervention. Based on all of these encouraging results, we proceeded with our single-arm clinical trial, which is called Robotic Exosuit Augmented Locomotion, or REAL for short. This is a short name for it. It's essentially a speed-based, high-intensity gait training program that uses a soft robotic exosuits. Within this clinical trial, we had 2 sub-studies. Study 1 is basically understanding how do we individualize the treatment for each person. The robotic device is very customizable. It has different settings. How do we even pick which setting is the best for a user, and does it even matter? And study two looks at the therapeutic effects. These are essentially the effects that are obtained after the gait training intervention, and how durable are these effects. Again, we're looking at, for study two, we're looking at effects on walking when someone's outside of the device. I'll start first with study one. And it's walking faster with soft robotic exosuits through individualized tuning by a clinician. We had two aims for this particular study. The first aim is to understand whether an exosuit with settings individualized to the user by a clinician was capable of immediately improving walking speed based on a single naive session. So I think it's really important for us to understand whether benefits in walking is possible if a clinician were to individualize the settings to each user. The second aim here is to understand whether there are any clinical characteristics that would differentiate those who respond immediately versus those who do not respond immediately. For this particular clinical trial, we used the commercial version of the exosuit, which you have seen in our the lab prototypes. This is the commercial version of that system. This is licensed to Rewalk Robotics. It has the same functionality as our lab-based systems. The advantage of this system is that the physical therapist can independently operate the device. So in our lab-based versions, an engineer has to be the person who's controlling the system. But for this one, this is independently controlled and operated by a physical therapist, which is really great. We included people who were over 18 years old. They had a chronic stroke, able to walk at least 6 minutes, and there's observable gait deficits. And we try to target those who had walking deficits that are more substantial. So that's based on a gait speed of less than 1.1 meter per second. We had 18 participants, and all of these participants were enrolled at Whittier at Bradford. On average, they had an age of 58 years of age. We have a good gender distribution. They are well within the chronic stage of stroke with a mean stroke onset duration of 41 months. These individuals would be considered limited community ambulators based on a comfortable walking speed of 0.7 meter per second. They're also very limited in their walking endurance, as you would see here in their 6-minute walk test of 241. This is about more than half of what would be an age reference norm. And here we have a good spread on their Fugel-Meyer, which is a bedside test on motor function of the lower extremity. This is our study flow. We started with a clinical screen and we did an exposure. We're looking at these two particular time points in our procedure as data points for this particular study. We'll talk about the other procedures in study two. But basically for clinical screen, we examined eligibility and we also obtained baseline clinical tests on walking function and the Fugel-Meyer. And then this exposure visit is basically a visit to get them introduced and acclimated to the exosuit. This is the first time they are using the exosuit. So they had a chance to kind of like understand how it feels and just get a sense of how it functions when they're walking. And importantly, this is also when we perform the tuning or this individualization procedure. And this is how we accomplish it. Again, this is done at Whittier, at Bradford. This is our speed-based tuning procedure. Essentially, we had 6 combinations of settings. These essentially correspond to combinations of different forces and magnitude, forces and timings of assistance on the plantar flexor. And these were then randomized. Each participant walked 30 meters at a comfortable pace and each condition was repeated twice, and this was performed in randomized fashion. Speeds were obtained for each setting, and how the tuning was performed was that the physical therapist identified the fastest speed, or the setting that generated the fastest speed that was above the minimum detectable change of 0.05. The MDC, or the minimum detectable change, is a threshold. This is what we regard as a threshold of a difference that is above measurement noise or variability. So this is what we found. On the plot here, you see graphs of numbers of people or numbers of participants who responded meaningfully or based on this MDC of greater than 0.05 across the 6 different exosuit settings. The maroon bar here, the maroon coloring here signifies the amount of people who walked faster, and the gray bars here signify the amount of participants who didn't have much of a change, and then the pink bar here is someone who walked slower, greater than the MDC of 0.05. So what is quite obvious here is that if you take a particular setting, most of the participants were walking at a no change. They were not walking faster, but their speed was not really changing above that 0.05. So if you take, let's say, if you take a particular setting, most likely people would not demonstrate speed changes that would be faster than the 0.05. However, if you look at the tuned setting, this is what the physical therapist selected based on the fastest walking speed with that MDC threshold. We see that more participants or more users are able to achieve faster walking with these tuned settings. And this corresponds with faster speed changes as well. So the takeaway here is that clinician tuning matters. If we want to optimize the system, we just can't give a person any setting or one default setting. A speed-based individualization approach allows us to increase the likelihood of people responding more favorably to the robotic exosuit. Well, this is all good. Looking at the group average, I think it is an incomplete picture of what's truly happening. So we looked at individual responses to see how people are responding to the robotic exosuit. In this graph, we show data of each participant. So we have the 18 participants here. The red bars signify improvements greater than 0.05. So 61% of our sample responded favorably in the single session of wearing the exosuit. So this is looking at how much their speed changes when they're wearing the exosuit versus not wearing the exosuit. So 61% of those individuals responded favorably, and 7 of which had even substantial changes of greater than 0.10 meter per second. So these are instantaneous speed improvements by simply wearing the exosuit, which is really encouraging. And if we look at the group average between what we would call responder and non-responder in this type of analysis, we see a 0.16 meter per second improvement in speed for those who had favorable response on day 1. This is very encouraging, and I think what comes to mind from a clinical perspective is more of like, is there a way for us to identify who might respond immediately to the exercise? Are there any clinical characteristics? So we looked at walking speed, whether there is a difference, and there is. So what we're finding here is that for those who responded favorably based on that walking speed, at baseline, there were slower walkers based on comfortable and fast walking speed, and they're more limited in terms of the 6-minute walk test versus those who are non-responders. Additionally, when we look at the Fiegelmeier uh, motor test, particularly the speed coordination subsection, we see again that the responder group has lower score, meaning they're more impaired compared to the non-responder group. I think there are two important points that are being demonstrated by this data. One is that for those who are in the non-responder group, they appear to have slower speeds and worse motor function, and still they are the immediate responders. Perhaps we are matching their neuromotor impairments with an intervention that's being provided by the soft robotic exosuit, which is essentially augmenting their propulsion, and they have an immediate response to that. And second, I think when we think of lower level walkers, people who are slower, we don't necessarily consider them for high intensity gait training programs, which are beneficial in promoting motor learning. I think this gives them an opportunity to engage in a more intense type of gait training program. With regard to the non-responder group, I don't think these analyses or these results are suggesting that they should not engage in a speed-based training program. Again, this is just a single session, and learning can still happen during the actual intervention itself. Again, this is only day one. So the main takeaway here is that it is important for the clinician to tune the device because it optimizes the effects on the user. And the second one here is that it allows people who have slower speed function to engage in more intense or engage in a speed-based type of an intervention in rehabilitation. I'm going to switch over to study 2. This is looking at the durability of improvements after engaging in a speed-based high-intensity gait training program with soft robotic exosuits. We looked at outcomes of walking speed and paretic propulsion, looking at the effects right after the intervention after 4 weeks, and looking at the durability of these changes after a washout of 1 month. And the third aim here is to look at the mechanism. Do we presume or we hypothesize that by improving propulsion, by targeting propulsion, we would be able to improve speed. This has not been shown by other studies yet, so we examined whether there is a relationship or not. This is a multi-site trial between or across 3 different sites, including BU and Spalding. 80% of our participants enrolled and received their intervention at Whittier. In this particular study, we looked at 3 time points. We looked at pre-evaluation, post-evaluation, and a follow-up period. We looked at the outcomes of walking speed, the 6-minute walk test distance, and propulsion. And I'm going to have Teresa talk about the intervention.
Thank you, Franchino. Thank you so much. I just want to share a little bit about what we did in this study so that when Franchino is coming back to share some of the results, you can kind of have a picture in your mind of what the participants went through and then what the changes might mean. And so I'll share with you what we did. And when I say we, what I really mean is Sandy and Angela and Whittier Outpatient, myself and another physical therapist did the training at BU, and then we had a physical therapist at Spalding. And so there's a framework of what the training was so that there's some generalizability of all the participants who went through, but there's a little bit of an individual component too. So I'll just share. So a training session is a research session. So these were patients who were coming in specifically for research, not necessarily for a physical therapy session, a research session. Before the session really got going, we took an assessment of the person's comfortable walk speed. So we knew what that was for that day. And then we could do a calculation to make the training speed. The training speed is 15% faster than the comfortable speed. So the goal of the training speed would be to walk faster than someone's comfortable speed. And the research participants knew it. So they knew that that was the goal, to practice this faster pace. And so the goal of each training session was to have 30 minutes total of walking. We broke it up into 3 10-minute bouts. So there'd be the first 10-minute bout on the treadmill, actually. And so because we knew what the training speed would be, we could set the treadmill at whatever this slightly faster than comfortable pace was. And the goal would be for the person to be on the treadmill 10 minutes in a row and keep up with the faster pace. The other thing that we did is we had kind of it's written here as kind of cue directed training. And what we mean by that is we gave a coaching tip to all the participants. And the tip related to some coaching cue to try to work on improving their walking, but improving really so that they could take advantage of what the exosuit wants to do. And the exosuit, they were wearing the exosuit throughout all the training. The exosuit wants to help push their foot away. That's propulsion. And so to take the most advantage of propulsion, some things that help are to have, say, the torso in an upright position. So if you have someone that really tends to lean forward or lean to one side with walking, one cue could be stand up straighter as you walk. Um, Another cue could be sometimes we actively had people try to push hard, push off with the as they were walking, and that would the exosuit was going to try to help them with that. And then sometimes even to try to get them to take a bigger step on the leg that was not affected by the stroke. When they take a bigger step with that leg, it puts the leg that was affected by the stroke a little more behind them. And mechanically, that's a better position to take advantage of what the exosuit wants to help them do. So the participants were coming in to train 10-minute round of walking where they had to keep up with a certain speed and they had a coaching tip from the physical therapist. And then we also had a little bit of a progression. So maybe if we could show the next slide, I'll just share the the walking training always had starting with a 10-minute round on the treadmill, and very clearly we could set the speed, so they had to keep up with that. And then they got the feel a little bit for what that faster speed was going to be because they just experienced it on the treadmill. The other two walking rounds we would call overground. So by that, we're just meaning anything that's not the treadmill. For the most part, this research was taking place in a physical therapy clinic. So kind of use what you have available. So either what kind of the longest stretch you might have in the clinic or maybe a hallway. So the other two bouts of walking in the session would be overground. And with the overground training, we would know what the distance was. So just say, for example, somebody was doing, say, 20 meters back and forth in the clinic. If we knew what the speed was and we knew that there was 20 meters, just hypothetical, say they had to make that in about 30 seconds for them to keep up with the speed. We could time them and then cue them as they went to try to walk faster and keep up with the training speed. And then additionally, have that coaching tip about, take a bigger step, walk up, try to stay up taller. We try to keep the coaching tip to just one tip because we're just not trying to overwhelm what's going on there. And then the other thing I'll say, you can kind of see on the slide here, all these kind of circles, the treadmill and then overground 1 and overground 2, they have these kind of arrows that go off in different directions. What's called continuous is meaning continuous assistance from the exosuit. So it's helping all the time, every step, always helping. But we can have kind of an example where, say, somebody was doing treadmill speed and they kept up with the training speed and the exosuit was helping the whole time, and that was great, and they did it. And so we wanted the program to have kind of a continuous challenge so that somebody wasn't always doing the same thing. One way we had to challenge is that we did kind of an intermittent assistance with the exosuit. So what we could do is every 2 minutes or so, we turn it off for about 30 seconds. So the person's trying to keep up with the speed, trying to use all the coaching tips, and now they don't have the exosuit working for this kind of little 30-second chunk. And then the exosuit would come back in. So it was just one more way to challenge them. And so nobody would kind of get stuck doing the same thing over and over because it was 12 research sessions. And so that would take anywhere between 4 to 6 weeks to get the whole program done. And then the other last thing I'll say is that we tried to challenge the environment. So you can probably imagine as someone's on the 10th training session, 11th training session, they've seen the same hallway quite a bit. So we would try to change as they were doing well and kind of progressing in the algorithm, like change the hallway to be a little bigger or take a different route, that kind of thing. So we try to keep them engaged, but one of the major principles is that the training was faster than their comfortable pace, and all of the coaching was relative to try to help them take advantage of the propulsion from the exosuit.
Thank you very much, Teresa. That was a great description of the intervention. In this particular study, we had 36 participants screened. 25 were eligible for the study and were enrolled in the study. 25 all participants completed the intervention and came back for the post-evaluation. However, we lost 3 people at retention. So we therefore analyzed all 25 with 3 to 5 participants excluded per analysis. On average, again, we had an average age of 58 years of age. People were very much well into their chronic stage of stroke with 43.4 months stroke onset. And this again kind of like reflects what we have shown in the previous study 1 sub-analysis with limited community ambulators of 0.7 and limited in 6-minute walk test. And again, even more impaired motor function here based on a Fugel-Meyer with 19. So what did we find? After the intervention, our primary outcome, we were targeting walking speed or walking function based on speed and distance, and this is what we found. We have here 3 bars, red and orange, are the results at post and at 1 month retention. So what we found was that people were walking faster at comfortable speeds and maximum walking speeds at magnitudes that were exceeding the MDC of 0.10, which is the more substantial MDC. Here we see a difference of 0.13 meter per second change, virtually sustained at retention. And similarly with fast walking speed. So both comfortable and fast, they were able to improve. And with the 6-minute walk test distance, we see changes that are above threshold of the MDC, 37.4, and even slightly longer at retention of 45 meters. So this is very encouraging. This is our target. We want to restore walking speed or walking function, but we don't really know if we are restoring walking function by not looking at what underlies walking speed, which we go back again to propulsion. So we measured propulsion, and this is what we found. At post-evaluation, we see a significant increase in propulsion of the paretic limb, and this is essentially retained at 1 month retention. Again, I just want to emphasize these are measures obtained walking outside of the device. So these are therapeutic effects that are maintained and are sustained without depending on the robotic soft exosuit. And this is really exciting. For the final aim, we looked at the relationship now between the change in propulsion and the change in walking speed, and this is what we found. We have 2 scatter plots here. The first one is at post-training. We essentially show that there is a significant relationship between the change in peak propulsion and the change in the distance in a 6-minute walk test, and the same pattern and same relationship we are seeing at retention. And this is providing evidence to our initial hypothesis that if we target propulsion, we can then see improvements in walking speed, thus providing support for propulsion targeting interventions in gait rehabilitation after stroke. There are several limitations. These are one of the 2 main ones. It is hard to understand the effectiveness of this at this point because we don't have a comparison control group. And even if we have 25 participants and it took us more than 2 years to complete, this is still considered a small sample size. So the next studies would effectively would need to add a control group and examine this over more people to improve on its generalizability. What we have shown in this particular study is that a speed-based gait training program that used a propulsion targeting device such as a soft robotic exosuit was capable of eliciting durable and clinically meaningful improvements in walking speed, distance, and propulsion function. And by targeting propulsion, we are effectively able to promote recovery of walking function.
And
We do, yeah. So Teresa, maybe you can kind of like talk about our ongoing studies.
I think we were going to say the same thing. So on that note, we do want to continue this work, and there are a number of different studies that are ongoing. We are always looking for participants. Some of the projects do take place a little more in the Boston area. There's this kind of stroke observational study that is taking place at Whittier, and you can see here, for the most part, these projects that are on active right now are for people who have stroke survivors and for people who have Parkinson disease. But if there were any questions about this work or about ways to be involved in research or any questions in general, either myself or Franchino would be happy to take questions after this in the discussion. But this email, GaitLab, it's all one word, at bu.edu is another great contact for any questions about the research.
Thanks, Teresa. I'm going to stop sharing, and maybe I don't know if there's any questions from the group. Maybe type it in, or I don't know what the best way is, but if there are any questions, do speak up or put it on chat.
I didn't see any questions yet in the chat, but we have plenty of time.
Yeah.
Can you hear me?
Yes.
Okay. So hello, everybody. Thank you so much for joining us. And thank you, Franchino and Teresa. This was an amazing presentation, as is your research. Guys, I am going to now send the eval tool to everybody. I'm pressing what I think is send. And there it is. I am also going to hit the link. And let's see. And there it is. Okay, so we know it does work. Okay, great. Okay, so folks, you should be able to hit that. I just give it a second once you hit it, and the eval tool does come up, and then you can just fill that out. So, are there any questions from anybody at all? I mean,
I see there's a message on chat from Pooja from Whittier, Westboro. I don't know if you want to write a question on chat, or maybe I don't know if they're allowed to.
they are absolutely allowed to write a question on
Hi.
chat. Just
Okay,
she
yeah,
wrote that, hi, this is Pooja. So
Hi,
absolutely.
this is me.
Oh,
I
there you
didn't
go.
know if I could unmute myself, so this is good.
Perfect. Thank you so much.
Hi, yes, this is Pooja here. So, you mentioned earlier about the standard AFO brace limiting the propulsive force during
Yeah.
the gait.
Mhm.
So, but that's the standard that we've been using for most of our stroke patients.
Yes.
So, do you recommend using it or not using it and trying to like harness that force during rehab?
I think there's, yeah, it's kind of like a technological challenge. Our toolbox is still limited. If there is a way, I think just kind of like being aware on when we need to use it, and then when we need to kind of like progress to the next device, if the person is capable of doing it. I know there are safety considerations with, let's say, in early phases of stroke recovery that might be necessary at this point. So I wouldn't necessarily say do not use it, but I think what we're trying to change in rehab practice is that, can we intervene earlier? This is what we're trying to change, introduce technologies sooner in one's recovery. If we can even start in the inpatient setting with robotic technologies, can we then change the typical trajectory of recovery? Again, this is still ongoing, so hopefully not aspirational, because I think there are actual studies that are exploring inpatient setting in other partner hospitals. I don't know, Teresa, if you had some thoughts on that.
I know this is something we all struggle with, because just to get somebody safely home, an AFO is what we have. And I think for the physical therapists in the audience, we've seen this time and time again, that someone's given a brace an inpatient, and that's what they needed at the time, but that's the brace they get stuck with for 5 years, and their needs kind of progress away from that in some cases, or in some cases that kind of learned misuse of, they just don't get the chance to propulse because of the way the AFO kind of locks them out. So this is definitely an ongoing struggle. And again, I wonder if something like the exosuit, delivered in the rehab journey, maybe earlier than say some of these research participants are getting it, would that make a difference? Because we recognize, I think the point you brought, Franchino, was so powerful, that the 6-minute walk test, the ability to kind of generate that much walking sort of endurance, is such a meaningful outcome. And training sort of faster walking and practicing propulsion, I think it does make a difference.
Thank you.
Thank you for the great question, Pooja.
Thank you.
Anyone else?
No, but I do want to make sure everybody does see the great
Okay.
response from Maureen. I think everybody feels the same way. I'm overwhelmed by your brilliance and dedication. I think we all are. What a wonderful life-changing effort this is. Wishing you the best. Thank you for sharing this.
Sure.
And I think we can, we all agree with that. Absolutely. You are amazing.
And I know it was said earlier, but a humongous thank you to Sandy and Angela at Whittier Outpatient, who did 80% of this training, and this good work was their work. It's just amazing.
Thank you so much.
One more question, sorry. In the studies that you mentioned towards the end, where we could email you, do you take like chronic patients with stroke and Parkinson's? Because we do get a lot of patients, and some of them are chronic and they get stuck with the kind of gait because maybe like the AFOs were not adjusted, and lack of care or something. So there are some patients who come to us even in the chronic stage and who want to get better, and they're stuck with that gait. So do you take those kind of patients for the study?
Yes, definitely. Sometimes each individual study has certain criteria, so clearly not every person would suit every study. But what we love to do, and we're trying to do, is create almost more of a database of all patients that are interested in research. And then we have kind of a visit that's almost like a screener to kind of meet them and take in their information and do some very kind of foundational tests like the gait speed and the Fugl-Meyer. And then they're in kind of a rehab or research rather database. So then we do have studies in the future that might suit them. Then we have their information right away. So please don't hesitate to contact that gaitlab@bu.edu.
It might be a great opportunity for many patients, especially the intervention studies, because it's essentially free therapy. And we also provide assistance for transportation. We can talk about it on a case-by-case basis, but we generally provide some assistance on transportation if that's an issue. And
Oh, that would be great.
so hopefully
Alright.
that's going to ease some of the burden in participating in these studies.
Yes, definitely. Thank you. Thank you so much.
Thank you very much. All right, well, wonderful. Thank you so much for inviting us. It's been truly a pleasure and a great opportunity to connect with the Whittier network. So thank you so much.
We appreciate your time. I know it's very valuable. So thank you again. This has been wonderful. Really appreciate it. And I think everybody has your contact info. So I'm sure everybody's going to be in touch with you in the future too. Thank you. Also, thank you to Dr. Breen for coordinating this from Whittier Rehab up in Bradford. Thank you, thank you, thank you. This was wonderful. Very, very good. So I think everybody does have the link there. I'm going to stay on even though our speakers have completed their program, but I will stay on just to make sure everybody has it. And of course, they can email me and I will get it to them. But I did try it. It does work. So anyways, listen, thank you so much. I appreciate your time. And hopefully we can get together and do another program because I'm sure you have other things that you'd love to talk about too. This is just amazing. Thank you. Have a great night. Thanks.
Bye-bye.
Bye.